Hi guys. Today's lecture that we went over in class, and it's just I'm just filling in on that, is our first day in the hospital. Where am I? What do I do? What is the procedure? So I will shorten this down and just give some general information. But these are all things that you need to know to help you get started. I know that you guys are anxious about the first day in clinic. That is normal. I can remember that first day also. It's like the first day on a new job. We all want, we all want to, when we go to the hospital as a student, know that it can be very nerve-wracking. Any new job, any new position can be stressful for us, especially if it's an environment that we haven't been in. And many times the hospital is an environment that is new to you, or is at least new to you as a student as opposed to being a patient or as a visitor. Some of you have worked in the hospital before or a medical setting, and that will be a help to you also. I guess the ground rule or something to follow is we are a guest in these facilities. When you're a guest at any place, you act like a guest. You control yourself, you respect the area that you are, and you follow the procedures or the rules that have been set up to there. Another ground rule, every clinical rotation, think of it as a job interview. And I don't mean every single day, but the area you are, we get calls back all the time wanting to know about a student that was in an area. And it can be a callback for a good reason or a bad reason. I want the callbacks that we get is because you did this beautiful shoe and this beautiful shoe, and you put your best foot forward. That is always think about that. That's probably good advice that someone gave you in the past. You only have one time to make a first impression. So be sure that you get a good first impression. It will make things that follow be much easier. Um, we talk about acting as a professional. And I like this thing over here, keep calm and act professionally. Well, I guess that's from the British thing, keep calm and whatever it is that the British said. When in clinic, keep a professional tone. This is jokingly saying no cursing, but that is true. Don't let your emotions get the best of you. The hospital setting in the hospital setting, you never know who you're working with. It could be an administrator, it could be a manager, it could be somebody important. But even that, no matter who it is you're working with, you want to be sure that you act professional because they're going to talk about the care they got at that hospital and the people that waited on them. Remember, you're wearing your HCC logo badge. You not only represent yourself, but you represent our college. We want to be sure that we stay in good standing with all of our clinical sites. We're not the only school that's in the game. There are many schools, and all of them are vying for the same clinical sites. I would encourage you to be friends with techs. I also would caution you. I have seen this more than once. Even as of today, we had a question about a student and being a little bit too funny and familiar, and the manager called. You want to be sure that you are friendly and approachable, but also you are a student. You can need to stay in your lane. Again, I don't want to sound scary or too cautionary, but I do want you to realize that you are a student and the text can be friendly, but just like anybody else that you barely know, they are not your personal friends now. Maybe later on they will be. So just mind your P's and Q's and be sure that you know your standing. Don't be too familiar. Let yourself be known and get to know them before you act a little bit too familiar. I love this SpongeBob here. We should be sponges when we're in the clinic. We are there trying to soak up knowledge and trying to be, you need to soak it up and you need to view it, hear it, and feel it. All of those things are going to go into their clinical rotation um, because we put into we put into the concepts with the practice in the hospital what we've learned at the lab. Just like when you came here, or if you go to the different machines in our department, they're much the same. But if you've done any observation in any clinical site, you know that there are many different types of equipment. So you'll be exposed to new equipment. that you've never worked with. Some of it may be better than ours. Most of it will not be better than ours, but it will be different. Different manufacturers, different brands. Remember, it all does the same thing. It may do it differently. It may take a little more work, but the exams can be done on the equipment. Also, you may be working with different positions than you've seen in lab. In fact, I can assure you that you will be doing positions in some of your clinical sites and lots of your clinical sites that will be different. It may be similar but different than the lab, and it may be completely different routine. So be open to that and be available to learning something new. And don't say, this is not how we do it in lab, because they don't really care how we do it in lab. The first clinical semester is learning the process of how the department runs. That should be your first thing that you do any place you go. This is going to be your first semester in clinic, but you're going to have 5 more first days in clinic. Every semester, you're going to have your first day there. Now, you may repeat some sites, but it may be different people you're working with. And also, you're going to be in a different semester, and there may be different expectations of you in a different semester. There will be clinical sites who will let you be very participatory very early on. There will be some clinical sites that will want you to observe and see and ask questions, and sometimes just observe before you start doing. So don't take it personally, but be available at all times so that you're ready there, that you're participating in whatever aspect they will let you, and show that you're interested. That is the main thing. Um, you will at first all of our exams will be performed under direct supervision, but you will begin to perform more exams on your own with less supervision as you progress in the program and even as you progress in the semester. So for the first couple of weeks, I can't stress enough to observe. Yes, I realize you're only there 10 weeks and or 1 day a week for 10 weeks, but you only have to do one clinical competency exam. You will have time to do that. I would rather you get to know what's going on and be confident than trying to do something you can't do. Know how to introduce yourself to patients. We've practiced that before here in lab. Learn how techs explain things to patients. Listen to how different ones give explanations. Some of them give very good verbal explanations. Some of them uh, more demonstrate how the position should be, and some of them touch the patient a good bit. Some of them do not touch the patient very much. None of these are right or wrong. Take all of them and use them as you can. Know how to detent or to how to position the machinery to get it locked into place so that it is ready to make the exposure. There are some machines that will not make an exposure until it is exactly in the right position. There's like a little micro switch and it must be connected. Others, it will let you make mistakes. They're not as helpful. Not as helpful for you to not to make mistakes. Find out about what to do when there are no patients. Is there something they want you to do? Do they want you to clean the room? Do they want you to stock the room? Do they care if you study some and bring your own material? What you're not going to do is talk on the phone. So if we look at the areas of the hospital, the front desk or the information area, not every place is going to have that, but you're going to visit clinical sites where that you may go pick the patient up in the room. Some of our outpatient facilities, you may be required to stop at a desk and ask something about a patient, or you may go directly to a patient's room and bring them to the radiology department. At different hospitals, you would be going to the waiting room, either in the emergency area or at the front desk. So this is where that you're going to get your patient and maybe have information about the patient, or you can ask things that you need to know. The registration, you won't do a lot of this most of the time. This person has been registered usually before you get to them, and then they may be in a waiting area after they've gone through registration. But it's where the patient gets all their paperwork done before we see them. Not everybody will have an outpatient area. Um, at some of the hospitals, they are inpatient. Now, you may have an outpatient that comes, but at other sites, it will be an outpatient facility, meaning that it is not a hospital, it is a clinic or it is a outpatient facility where they just deal with outpatients. If you're in a hospital, you may be dealing with some outpatients and some inpatients. So it's and every hospital may have an outpatient section where the patients are just coming in for an exam or for observation, and you may get them from the outpatient area. It just means that they're not spending the night in a hospital. Obviously, pediatrics goes without saying. It needs to be a little place that is a little more child friendly. You may see the techs wearing uniforms that are different than the rest of the hospital, that may have cartoon carriers or characters or things that are more child friendly. The decorations there, this is an example at Memorial Hermann Children's Hospital where the walls are painted and decorated differently. This is also a waiting area that has a simulation of tree trunks in the area. So you may see something that's more child friendly or a little bit less intimidating for a child to make them a little more comfortable. And you will see that in some of your exam rooms also that are specifically for pediatrics. The ER or the ED is where we come for emergencies. In my day, it was called ER for emergency room. ED is the emergency department, which is probably a better terminology. The patients can come in here for severe trauma, level 1 trauma center, which is what Herman is, or they could come to the emergency room for a cut, scratch, bump, stomach ache. So you will see all varieties of that. And so we may do emergency x-rays that are very critical, the patient's in critical condition, or the patient is just sick and uncomfortable. OBS is observation unit. This is may be associated with an ER. The patient may not be sick enough to admit to the hospital, but they need to be observed, or it can be a holding area that for a patient that needs to be observed and monitored before they go to their be admitted into the hospital or to their room. Many times we will do a portable X-ray in the clinical observation area. The PACU, or the it stands for post anesthesia care unit. It can be a pre-op area and a post-op area. You can go to the PACU. It could be post or pre-op. Sometimes that's the same area. They will have you there, getting you ready to go to getting the person ready to go to surgery, and then almost everybody who has surgery is going to spend a little bit of time in a post in a PACU. You may have heard it in older times called the recovery room. That was where they recover after surgery. But the patients need to be monitored because the patients have come to surgery. They've got to be sure that they can breathe on their own and that they're waking up. And they may have other functions that, according to what their surgery was, that they may have to accomplish. They may have to have a bowel movement. They may have to have pass urine. So there might be several things. They may have to be able to answer some questions. They may even have to be able to stand up and walk. So there's a whole bunch of different areas that might be associated things in the PACU, but it stands for post anesthesia care unit. In the ICU is intensive care unit patients, and we've divided the ICU up into different ICUs: the cardiac care unit, the intermediate care unit. We may have a spinal care unit, a spinal ICU. We may have a psychiatric ICU, but the ICU is a step up. It's where you have more critical care or more observation and things going on than just on the floor. This picture here shows a lot of things that are in the ICU. This is a mannequin here. I think maybe if you go to this website, I'm not sure here that it will explain these things to you. But on the next slide, I've talked about some of the things that you can see in here. Maybe you can go back and try to identify them. If not, you can try to identify them when you get in the hospital. And so here's some of the things that we might see. A blood pressure cuff. It does just what it says. Many of you, all of you have had your blood pressure taken if you've been to any kind of medical facility at all. It gives you your blood pressure. The central venous catheter. Maybe you're not familiar with this. You're probably used to seeing an IV in the arm where you put fluids in the arm. A central venous catheter can be in the periphery, it can be in the arm, or it can start in the chest. What it's doing is putting the catheter is going all the way, or the tube or catheters going all the way into the right atrium or the superior vena cava. So it is delivering medication directly into the bloodstream, and it's for long-term use, not just in the periphery. That might just be for short-term use. An endotracheal tube, ETT, or just ET, more commonly, or it might be called a breathing tube. More often, you're going to see this as ET as opposed to ETT. It is something, a tube that is put into the trachea to help so that the patient maintains an open airway and breathing. People that are on the endotracheal tube will either have an ambu bag attached to them, or they will have be on the breathing machine or the resuscitation machine. The ICU bed monitors are all those things that you see beside the bed that tell you the patient's vital signs, their temperature, their blood pressure, their pulse rate, their respiration rate, and their O2 saturation. It may also have an EKG monitor so that you can see the EKG on that monitor also. An indwelling urinary catheter is that catheter that you have so that you can pass urine. And that is usually put into most patients who go to surgery, but not all. If you're bed bound, you may see that more often also. A nasogastric tube, commonly called an NG tube, is a tube that goes through the nasal cavity and down into the stomach. It on some occasions it go into the small intestines, but usually it's going into the stomach. It is to withdraw things out of the stomach, and also it's called a feeding tube. So an NG tube, a feeding tube is a type of NG tube. Or an NG tube can be a type of feeding tube. You can feed from it. I guess what I'm trying to say is that you can give nourishment through the tube, or you can withdraw things from the stomach via that nasogastric tube. Resuscitation bag, that's the ambu bag. That's the bag that it looks like a balloon type thing or a football, and you mash it, squeeze it, and it delivers oxygen into the endotracheal tube. Or if they had not have the tube put in yet, if you were doing resuscitation, you would do that before an endotracheal tube has been put into the patient. A saturation monitor or pulse oximeter, commonly called, it is hooked onto one of the fingers in this particular way. It sometimes might be on the earlobe. This is a monitor that tells the oxygen saturation in the blood, which should be somewhere between 95 and 100. A sequential compression device is something that's hooked up. Not every patient is going to have this, but patients that have had surgery maybe on their lower extremities, or if they've come in and they're going to be in the bed for a long time, these are cuffs that are put around them, much like a blood pressure cuff, and it on a timed basis it inflates and puts pressure on the leg or the lower extremities, and then it releases. This is to facilitate circulation, to get blood flowing back up to the heart away from the lower extremities. A syringe driver or syringe pump, that is just going to be what we would call an IV pump. It's where the IV, the intravenous uh, line that's going into the patient. It is so that you can control the flow of the medication or the fluids or the saline or dextrose, whatever the patient's getting. It can be programmed so that it gives a certain amount over a certain period of time. And a ventilator is what many times we call the breathing machine. It is the machine that can be set to a certain rate and a certain volume to deliver oxygen, to deliver breaths to the patient. It will have oxygen mixed in there also. This would be hooked up to the endotracheal tube. So the IC units can be a little overwhelming when you first see them because the patient may be unconscious, they may be hooked up to all of these things that I just said, and yet you've got to go in there and try to do a radiograph. So there may be certain things that are sterile in there. You may actually have to wear a gown if they have contact isolation, or if they have respiratory isolation. You may have to wear a gown and a mask, and we're always going to wear gloves. Uh, our main thing is we don't want to disconnect or undo something that somebody has. If you need help, don't hesitate to ask. As a technologist, the technologist should also be willing to ask a nurse or anybody else, healthcare professional, to give them a hand. You can be a vital role as a student. That's one of the things they can be, is a vital role and get to be a team player by watching what's going on, being able to lift, shove, move, or watch to be sure that something does not come undone or unplugged. So you could be a great help in that situation. It is a little unnerving the first time you see it. Vented patients in ICU, obviously, we want to be sure that we do not disconnect. This is one that has a trait going in here, endotracheal tube. We want to be sure that we keep the oxygen, uh, the ventilator hooked up to the tube so that the patient is getting a breath. The NICU, the neonatal intensive care unit, I've had less experience here, except when years ago when I was a tech, because I haven't really worked in a pediatric hospital, and in the pediatric department, I don't go up and do portables. But this is where most of these babies, we can bring them down to the department, but many of the times their X-rays were going to be done portable because these babies may need to have a chest X-ray done every day to see the condition of the lungs, because most of them, well, obviously they're neonatal, so they're premature. There may be a lot of people, a lot of things going on in there. These babies are having multiple x-rays, so you want to be sure that you do the x-ray right the first time, and also that you are doing everything that you should do and being sure that you don't disconnect something. There will always be somebody there working in that area. So be mindful of radiation protection and equipment surrounding a baby, and you may have to take extra precautions on being sure everything is clean. Everything should be cleaned anyway. There may be extra precautions they want you to take there. The MIU is the intermediate care unit. It just means they're not as critical as the ICU, but they're more critical than just a floor patient. Um, you will just do general X-rays in that area too. And the inpatient med surg floors, those are the general floors. The patients are they could be post-op, and sometimes post-op patients come directly to the med surgical floors. They don't need to spend time in an intensive care unit. These are just just the general patient care rooms, and we will do portables in these rooms also. In the radiology area, sometimes called the radiology department or the imaging department. And in large hospitals, it may be divided up into different pieces where that everything is not in the same area. But there also may be where that you see CT, MRI, nuclear medicine, ultrasound, all in the same general area. Even in big hospitals, they're usually in the same general area, maybe not always on the same floor or in the same department. It's important to know where these are because many patients are coming and they come to the imaging area, to the radiology area, and they don't know if they need an X-ray, a nuclear medicine exam, an ultrasound, an MRI, or a CT. So you may have to help them decide not what they're going to have, but where they need to go by asking them a few questions. And so you should know where to take them to get their exam done, or that front desk or that registration area to get someone who does know and can help you. Pharmacy, we're going to have very little to do with. I'll just leave it at that. Laboratory, probably we won't do a lot with a laboratory either, but there may be times where we're required or requested to take a sample down and turn it into the laboratory. There's some the exams that some laboratory work that sometimes needs to be done before a patient has our exam, but most often it's going to be that if you were working in CT or that you were working in interventional or for myelography area where that we obtain CSF, cerebral spinal fluid, that we take it to the lab. And sometimes it may be our job to take it there, it may be a runner's job to take it there, or it may be a nurse. But that's the things that we'll do with the laboratory. There are some lab values that we have to check before we do some exams, but we don't really have to go to the lab. That will be on the patient's chart that we can see. Cafeteria, well, that stands to reason what it is. So let's talk about the patient. When it comes, when patients come to us for exams, it becomes our responsibility to do certain things. We need to interact with the patient, establish and maintain an atmosphere of caring and empathy for the patient, but not getting too involved. Treat the patient as a guest in our home, or I like to say, treat the patient as you would like to be treated and as you would a family member. Now, that's assuming that you like your families. Not everybody is going to like every one of their family members. But remember, this patient is somebody's family member. They're a husband, a wife, a partner, spouse, child, grandparent, brother, sister, aunt, uncle. There's something to somebody or a friend that cares about them. So, uh, our patients are going to remember us. I'm amazed at how often patients remember us and also how I remember a patient. And you may have a brief interaction, but your influence on them, either bad or good, is going to be remembered. We need to establish good communication with our patients or with in the case of a pediatric hospital with their parents or their guardian or whoever's with them. You might, if it's an elderly patient, you need to have good communication with whoever's their caregiver or whoever's with them so that everyone understands what we're doing and why we're doing it. And again, it doesn't have to be a detailed conversation, but it needs to be good communication so that they know they can ask a question or if they don't understand something. That's the best way to not make a mistake is let a patient know that they can ask a question. Um, this says be respectable without being too familiar. Yes, they while they are people that we care about, they are not our personal friends or our family members. So give them the respect that they need, and you can gauge how familiar or unfamiliar they want to be with you. Empathetic without being maudlin. Don't be tearful or emotional, but yet let them know that you understand and care about what's going on with them. Considerate without being too solicitous. Uh, don't be too fearful, don't be too over concerned, don't increase their anxiety, but you can listen to them and maybe you can lessen their anxiety. But do not offer medical advice. It is not our job to give medical advice. And don't say everything is going to be okay, because many times everything is not going to be okay. And you start doing that and you get it off into the weeds of telling people, giving people false hope. And that is not our job to tell them things are going to be okay. You can tell them that the radiographs was successful, that they were adequate, but we're not giving diagnosis on those either. You can be professional without being cold and clinical. Always thank the patient when you're through. And as this slide says, be our guest, be our guest, be our guest. Treat the patients as if you would treat someone that's a guest or a family member. The patients choose to come to us. Remember, they could go to other hospitals. That's not always true, but it is many times they could go somewhere else. Introduce yourself to them. Just think about something else. If someone comes to get you or take you somewhere, don't you want to know who they are and where they're taking you? I think that's a common thing. In the hospital, people are being approached all the time and to have things done for them or things done to them. And so, just out of respect, you should let them know who you are and what you're doing. Again, that gets back to our good communication. Also, we don't get to choose who we do, and they don't get to choose all the time where they are. No matter if our patient, no matter what their age, their ability, or their disability, we still treat that patient the same. Let me rephrase that. We treat that patient with the same respect and give them the best medical care we can. We do have to sometimes treat them, when I say treat them differently, approach them differently, because you would approach a child different than you would approach an adult, and maybe someone that is older, or maybe someone that has a memory problem, Alzheimer's or dementia. They're all treated differently. A psychiatric patient, you have to gauge what you're going to do. But the bottom line is you're still treating them. We don't choose what kind of patient we get, and we still have to get the best care that we can give and get the best radiograph for their diagnostic outcome. The patient's condition does not change the importance of what we do. Uh, we're a caring profession, and we should act that way all the time. So, what can we do the best for our patients? We can be knowledgeable about the exams that we're doing and how to do them. You are learning those kind of things. You will learn them progressively as we go along. You can be prepared. Even if you do not know everything that's going on, you can look and observe and be prepared. Uh, uh, do more in less time. Get the room ready if you can. Know where things are so that you can access them immediately. And that goes into the efficiency. Uh, a satisfaction of the patient, the physician, and the management uh, uh, all depends on us being efficient and doing our job well. Sometimes we talk about separating what we do in the lab from clinic. We teach one thing in lecture and in lab. These are correct things. This is what you're going to be done on the test we have. That's what you're going to be tested on the test that we give you here, and also for the national boards, the registry. In clinic, you will learn many things that you don't learn here that are beneficial. There will be some tips and tricks that every technologist does that you can learn from them, how they do it better or more efficiently, or how it pertains to their institution specifically, or the doctors at their institution. You can bring things you learned to lab, things you learned in lab to clinic, but don't try to bring things you learned in clinic back to lab. Just because they did it in clinic that way, do not come back and say this is how we're going to do it in lab, because you're going to be graded on how that you were taught in lab. You want to be a whole person when you're in clinic. There's the cognitive, the affective, and the psychomotor. The cognitive is the actual didactic or book work that you learned in class and in laboratory, where you learn, memorize, understand, synthesize all those things. Then the affective learning involves your attitudes, your values, and your feelings. Those are really hard for us to teach. You have to have something inside of you that wants to have a good attitude, that wants to understand your feelings and the feelings of other, and it gives value to what you do and what you say and how you act. So effective learning, sometimes those are called soft skills. And then there's the psychomotor learning, is the actual hands-on, the phase of doing. Some people are much better at the hands-on, actual doing, assembling, putting together, positioning, and some people are better at the research and studying. But all of those have to go together for us to be an effective tech. So you have to have the cognitive learning, the affective learning, and the psychomotor learning, and put those all together. Some are easier for us on one aspect than they are for other. Um, Observing and assisting, well, to start with, we're going to do much observing and assisting. The assisting may be handing things, listening to things, cleaning things, but you will be available for whatever's happening. Um, you may work with a radiologist or you may not work with a radiologist, especially in this first semester, because you will be doing very little fluoro in most places. And so that's where you see the radiologist most often. Starting, we will be under direct supervision. That means that we're anytime we're in the hospital or a clinic site, we are under the supervision of a qualified radiography. We have to be, because that is part of what the radiography profession, that's what the hospital, its policies and procedures are going to say, that a qualified radiologist did or supervised a person's exam. Um, Direct supervision, again, is going to take place much more as a new student. Uh, the person is going to be very hands-on with you. The final of approval, now you may have some leeway, but they're going to watch you very closely and probably be right with you. I've had a student that told me that me being so close made them nervous, and I told them, well, watching them do things made me nervous sometimes. I don't think that's really a wise comeback, but I will say that students have made me nervous watching them do things. The final approval for any radiograph that we make must be done by someone who is employed by the institution where we're working. We get better by doing repetition, repetition, repetition. Indirect supervision is exactly what it says. There's still a technologist that is in the immediate area, sight, or sound of you, but they may give you much more leeway. And especially as you progress, second year, you will have a lot of indirect supervision. They will be there, but you may let you do everything yourself, everything except do the final approval for that film. So, what is a competency? We talked about competencies. You've been practicing things in lab. Some of the things you practice in lab, I think you're going to do something called a practicum in lab. The competency is much like that, except you're doing it on a real patient. If you want to go to this website, it will talk to you. This is from the ARRT guidelines about competencies and what's evolved. A competency basically for us is saying that you're going to do the procedure from start to finish, from getting the patient, introducing the patient, being sure that you have the right patient, give them the communication that you need, that you position them, that you can set the machine or understand the settings on the machine, that you make the exposure, and that you dispose of your patient. When I say dispose of them, I mean you put them back, take them back to the waiting room, put them back in the wheelchair, put them back on the bed. If they're in the bed, cover them, get their cover straight. You're going to see that that's done. If you don't do all of it, you're going to oversee it. You can't hold a film. Sometimes a patient has to have someone to hold the when I say the film, look how old I am. When you hold the IR, we are not to do that, but you're in charge of that for a competency. In your 2 years here, you will do 36 mandatory competencies and 15 out of the 34 elective procedures. There's a good many procedures that you will not see or do, or that you will see them or done at very limited areas. And there's some that you will never see done in this area. The way HCC has planned it, you will complete all 51 competencies by the end of your sixth semester. And then there will be 4 more competencies that we call a terminal competency. You will, in that final semester, you would do 4 comps that you have done in the previous 5 semesters, and you will be, quote, retested on them. Where to start? Well, start at the beginning. Become familiar with the full operation of the X-ray room and tube and table. How does it move up and down, vertical, horizontal? Uh, most rooms are going to have a ceiling mounted tube. How to move that tube, how to lock that tube. Um, so the tube, the table, you need to know how to do those. Fluoroscopic room, be familiar with how the image intensifier moves, uh, how you move the bucky to accommodate this. You will probably do much less of this your first semester. You do need to become familiar with the control panel, maybe how to pull up a patient up, how to assess that patient to get them out of the RIS, out of the radiology information system or whatever system they're using, that you can see that patient, that you can see their name, their date of birth, their MRN number, maybe their accession number, and the exam that is to be completed on them. And then you will set the settings on the machine. Probably the KVP for sure, and then maybe the mask, or you may use automatic exposure control or an automatic technique uh, prompt. All of those you should be able to look on the machine. Many machines will have you can choose a different patient size that would choose the exposure. So be familiar with the fundamentals of the X-ray machine, the things that you have there. You're also going to be aware of all types of procedures that are done in this room. Well, obviously, you can't do a fluoroscopic procedure if you're only in a radiographic room. You can do a radiographic procedure in an RNF room. An RNF room means it can be used for general radiography and it can be used for a fluoroscopy. Not, but the table in the general and the table in the fluoroscopy room is not going to operate exactly like the table in a general X-ray room. Locate where the appropriate supplies are in the room. Gowns, emesis basins, uh, for sure emesis basin or bag, washcloths, sheets, any kind of covering device. There may be a warmer device to keep blankets warm. Know where things are in your room. Become familiar with the full operation of the wall bucky, how it moves up and down, if there's something that makes it move fast or slow, the handles to hold to the patient, like for doing a lateral chest x-ray, that bar across the top, how it moves, how it opens. They're really different in some areas. They're hard to move in some areas. Some of them, they unlock easily. If contrast media are used in any procedure, become familiar with their preparation. You will probably do very limited amount of that this first semester because that would be a fluoroscopic procedure. Tasks to be performed: set up the room for each procedure before the patient is brought into the room. The more you can do this, the easier your life will be. You will be less nervous. You will be better prepared. Your room will be ready. Then you can focus on your patient. Assist with performing all imaging procedures in the assigned room. If it's necessary to consult your notes, that's okay to do so, but do it behind the scene. Do not grab your notes out as you're looking at the patient and saying, "Oh, I'm supposed to turn you a little bit here," and then you turn them. You can review your notes, but keep them out of the direct patient exposure area. Uh, you're an adult pursuing a new career. Take charge to the best of your ability. If in doubt, ask the registered technologist all questions, but not in front of the patient. Reserve your questions for when you are just with the technologist for them to explain, because it will give them more time, and also it can reduce any embarrassments of somebody not knowing what they're doing. Some other things that you can do. Courtesy is essential for providing service to the patient during the greeting, procedure, and the dismissal. Again, I tell you, I always like to use say thank you to a patient or some closing remark. Even if you think the patient can't understand, you might say, the transportation is going to take you back to your room now. Something so that you address the patient. Uh, Position the patient professionally and confidently. Be mindful of how you're touching a patient, as we've talked before, of keeping the patient's modesty preserved if at all possible. And you can position the part to be radiographed, adjust it, and make an exposure. But get in the habit of not just moving a quarter of an inch one way and a quarter of an inch back the other way and a quarter of an inch one way and a quarter of an inch back the other way. Do it with some confidence and know that so that you give the patient the confidence that you know what you're doing. Initially, you may have to ask the radiographer with whom you're working how to set the exposure technique. That is true. You haven't gone over exposure and techniques much this semester. That is next semester with Mr. Daza. But you can start seeing what they're doing. Be observant of what the mass was on the exam that you did or that they did. Look at the size of the body habitus of that patient. Try to match up what you looked at the patient, how the image looked, and what the settings were on the machine that got you that image. That's where you start putting it all together. After completing the procedure and dismissing the patient, you should critique the image with the technologist or with one of your faculty members if you have the chance to do that. Now you may have back to back to back patients that you're not able to do that, but when you have a little time, you want to critique the image. What was good, what was bad, what could be done better, or what could be done differently. And just because the image is critiqued does not mean it was done wrong. We can talk about how the habitus of the patient, how we could have done something, or the disability of the patient, or the hardware that the patient had that prevented us from doing hardware. I mean, like implants or for surgery, things that you can't change on the patient. Immediately prepare the room for the next patient. You could be dumb as a brick and not know what's going on, and you can clean a room and you can get prepared for the next room. You can put things back where they came from. You can clean, you can straighten up a room. Be proactive, anticipate the needs of what's going on. That comes by being observant of your surroundings and what someone else has done. Okay, if we talked about things we can do when our clinical time, when we have some free time, if it's not really busy in your area, and you're going to talk to your classmates. Some of you are going to be in areas that are much busier than the others. Their time will come to be in a not such a busy area, and your time will come to be in a very busy area. You can always, again, the first day or two, watch what the techs do or ask them. You can be upright. Is there anything particular I need to clean? Well, you always need to clean after every patient. Are there any things I need to stock? Where do I get the stock from? There usually is an area where you can get the gowns, the sheets, the pillow slips, anything else that you might need. You might ask where that is. That shows that you're interested in what's going on. Again, you can always clean anything in the room. That should be done routinely. And when you do that, it shows the technologists that you're working with and us as clinical instructors that you care about your patient, you care about what's going on. You can practice positioning using one of the technologists or another student or whoever you have, not the patient, obviously, but whoever is available in some downtime. That's also a good time to work on the equipment where you can ask questions about how the equipment works. Or if you didn't understand something, it's hard to do that with the patient on the table. But when the patient's gone, then you can say, well, can I practice moving that machine and lining it up on you or another student? Go through your notes and review positionings and centering points. You can always do that. You should have a notebook in your pocket where you can make notes of things that you need to see, do, and remember, specific maybe to that room or to that area. Uh, you might check to see what other procedures are scheduled so that you know what's coming up. That may be that you may have that ability, you may not. In certain areas, they will have the patients listed, especially in fluoro and in pediatrics. They may have listed of what's scheduled. Other places, you won't have the ability to do that, or the technologist will have to help you do that. Clinical hours are for clinical education when that means that you should be focusing on what's happening in clinic. I've said before, you can use your notes. You can bring your notes. I would encourage you to at least have them with you. I wouldn't get them out on the first day. See how the tenor, how that department works. If you can tell if they think it's okay for you to have your notes, and there's some areas that will be true and some areas that will not be true. So you just got to be observant and gauge your area. What you're not going to do is get out your phone. I think I've said that 3 times. I do not want you to be called out for that, to lose points for that, and for management to contact us. First time doing an exam, here's a guide of what we could do. The more you have a routine and a checklist, the more you have a recipe when you first start cooking, the more you have a recipe and directions to follow, the more efficient and the more confident you're going to be. Introduce yourself to the patient. Again, if somebody comes up to you and is going to ask you questions and take you somewhere, you're going to want to know who they are. So they want to know who you are, and then you want to verify that you have the correct patient. This is the same routine that we've gone through in practicum, but I can't stress it enough because you get nervous that first time, and it's okay if you mess it up the first time. Don't worry. I'm going to be with some of you at Herman and Methodist, but especially at Herman, I'm going to say, tell the patient who you are. Tell them where we're from. I might remind you of that when we're going to get the patient, and we're going to the vitally important. I want you to introduce yourself and tell them where we're going. You cannot do an exam on a patient or even participate if you have not verified that patient. We usually use their name, their MRN number. They're not going to know that, but we will have it. We can look on their armband. They should know their date of birth, and we should verify what body part or what they think we're doing. They may not know, but we can give them the chance to tell them what we think we're doing. Today, in the hospital, we had an order for a foot x-ray, and the patient said, no, it is my left foot, and the orders clearly said right foot. We had to hold her there. She was understanding, but we had to call and verify which that we could not change that order to her left foot. We had to call and verify. But without asking her, if we had just done that and she thinks we're doing something else, communication, communication, communication. You're going to give the patient instructions on how to dress for that examination. Well, if I'm doing a foot exam, I need their shoe off. If I'm doing a KUB standing, I do not need their shoe off. So look at what you're doing and how they should be dressed. You may obtain a patient history. Sometimes that's vitally important. Sometimes it's not. And in some places, we're not going to do much of that. But you usually are going to get a little bit of information about the exam we're doing if they've had surgery. They may have a rod that's implanted. If they have a rod in their leg or their arm or their foot, we have to get the entire uh, medical device that's been implanted. Uh, if there's a radiologist present, you're going to introduce them. You're going to perform the exam and you're going to release the patient. Again, you're going to close out by thanking the patient and giving them any advice or any instructions, not advice, any instructions they need before they leave. When calling your patient, be sure to introduce yourself. We've said that already. Uh, you can do that. Just practice introducing yourself to anyone. You should be able to do that. Verify the patient. Well, that depends on where you are. This patient here has numbers. It has a date of birth. It has their name on there, so you can use that. But you still want to get it, verify it with the patient, not just their band. If you're in a pediatric area, the neonatal, the pediatric patient may not have this band on them. It may be on a piece of equipment or in their bed, or it may be on their parent or guardian. Either way, we have to be sure that we know that this patient is the patient we're doing. That is your quickest ticket to be fired from a hospital and your ticket to be out of here. Usually at a facility, they use two unique identifiers: name, their date of birth, and then we're going to look at their MRN number. We should have that in our files. If it's an outpatient, you may not have any kind of armband on them that tells those identifiers, so you have to verify it verbally. But these outpatients are usually patients that can tell you these things. Some places use a wristband on the patients to verify the MRN numbers. That is very common if they have one, a wristband. When we're getting our patient to the exam room, we may take them in a wheelchair, on a bed, or on a stretcher. All three of those things may be how we get them there. We may walk them down the hall. They may have a walker. They may have a cane. They may have a scooter. So just be aware and just do assisting. Don't over assist, but assist your patient in getting to where you're going. Ensure your patient is safely gets there. If it's a long distance, and they don't seem to have any kind of aid, you might try to get a wheelchair or see if there's something available to make their journey more comfortable. And in some areas, it can be a long ways from a waiting room to where you're actually going to do your exam. Um, Again, if needed, provide the patient with whatever they need. Again, determine how the patient needs to dress. Think critically. Think if you can see it, on the patient or in the patient or around the patient, the x-ray is going to see it too if it's in the radiographic field. So just think about what you're doing. What might a patient might have on? A patient might have a bra on. A patient might have a necklace on. Well, you should obviously look, if you're doing anything, the head, neck, face, that they take off glasses, if they have hearing aids that come off. You're doing arms, rings, bracelets, all those kind of things. So just be aware and make it critically. If it's thick clothing, if it has clothing that has glitter or paint or written on that, that will show up on an X-ray too. Many times jeans will show up. Jean material will show up on an X-ray. Braids in the hair will show up if they hang down on the back. You can see them on the chest X-ray. So get things out of the line of the light field that you do not want to see on an X-ray. Obtain a history of the patient. Again, that is going to be variable, but you're probably going to get at least some light history. We're doing your hand X-ray. Do you have pain in your hand? Were you in any kind of accident or trauma? Because you might be looking for something different if you're looking for gout or swelling or arthritis, as opposed to if you're looking for a foreign body or a fracture. And this is also when you can verify the exam that you're going to do on the patient, what it is you're going to be doing. See if what the patient tells you matches up with the information that you have either on a paper request or on the electronic request in the machine. You might ask them something about if it's their, which body part it is, and they may tell you it's another. If it does not match up, you must stop and verify that before you go any further. You're going to explain the exam to the patient, but don't give too much information. Say we're going to do several images or several views. I will be asking you to turn in various positions or to move in several different ways or to change your position. But they don't need to know if I'm going to do this AP or PA because that doesn't mean anything to them. Just tell them clear, concise directions. I want you to lie on your stomach. I want you to stand with your chest or your back facing this. Letting the patient know what is going to happen will ease their anxiety almost always, and they usually will be more cooperative with you. Again, I'm going to skip over this, introducing the radiologist, because we're not going to do that. Performing the examination again. You know what you've done, you've been trained, you care about your patient, and you're going to do it as efficiently as you can for your time and for the patient's time. Keep the patient informed about what's going on. If you need to leave the room and go check on something, or you're looking at something, say, I'm looking at your image back on the monitor, or I need to get this, or I need to do that, so that they know what's going on with you. Again, I can't stress communication is important. Be sure to tell the patient if you're going to touch them, even if you're touching them in an area that is not considered a sensitive area. I'm going to move your hand or your foot because it may be sore, it may be swollen, it may have something that you can't see, and they may be leery of you touching it. Now, you may have to touch it, but let the patient know what you're going to do. Again, when we're through with our patient, we're releasing our patient. We're going to leave them in a friendly manner, assist them if they need to go somewhere in directions or physically take them somewhere. We want to be sure that we close out on a good note because usually we remember the last thing that happened to us. If you had a bad experience, but something very good happened at the end, you tend to remember the very good. On the opposite, if you had a if you had a very good experience and something happened on the bad, it's the bad taste that you take with you. So ask the patient, are there any other appointments before you dismiss them? If it's a walkie-talkie patient, or because there may have other exams while they're in the outpatient area. Starting in clinic is one of the best times of the program. I think it's where we put the pedal to the metal. It's where we put into practice what we've learned. Most of us did not want to go to X-ray school to study a book and to study in the lab. We wanted to actually do live patients and see the fruits of our labor, see what we've done. It's exciting to see a radiograph that you know that you participate in, that you help make, and especially when it's something that reveals information to the doctor or to the diagnostician, whoever it be, the doctor, the nurse, whoever it is, that you participate in getting the information they need to help that patient become better or to alleviate their pain. It can be daunting to be in the clinical setting, but it's also rewarding. We will talk more about clinical policy and procedures. We will actually do this on our opening day of clinic, which will be this week. And I encourage you to look forward to this. It's an exciting time and enjoy it.